Welcome back to the Deep Dive, where we commit to mastering the most complex fields of knowledge by extracting the essential, high-level insights from dense source material. Today, we are undertaking a deep dive into an area of the body defined by its immense challenges, the surgical anatomy of the thoracic spine. This is a region where precision is not just expected, it is, well, absolutely paramount.
It really is. This is often called the definitive danger zone of spinal surgery. The anatomy here, it's just unforgiving.
Unforgiving how?
Well, you've got extremely tight working quarters right next to the spinal cord, the great vessels, the thoracic duct, and this unique valveless venous network.
Right.
So our goal today is really to unpack the core procedures, the inherent risks, and, the meticulous anatomical understanding that separates the real expert practitioners from the merely competent. We're aiming to understand this field with the mastery required by elite professionals.
Okay, and our sources for this are technical excerpts focused on clinical anatomy, core procedural steps, and crucially, the critical hazards associated with navigating the mid-back. So this isn't just about identification, it's about understanding the calculus, really, behind every single surgical decision.
That's the key. Our mission is to understand the inherent, multi-layered risks, vascular, bony, neural, lathe, and analyze the sophisticated surgical techniques developed to negotiate this intense complexity successfully.
Okay, let's unpack this then.
Yeah.
And maybe we should start with what seems like a basic, almost embarrassing truth of spinal surgery. The challenge of simply finding the right spot.
Yeah, it sounds basic, but it's a foundational challenge and one that's still responsible for a significant number of errors. Wrong level surgery.
Right.
And the very feature that makes the spine seem accessible, the prominent superficial back, it actually provides some of the least reliable guides in the thoracic region.
It's funny, when we're in training, we're taught these neat sort of geometric approximations, but the source material is emphatic here.
Yeah.
They're basically an illusion.
They really are.
Maybe we should list them, just for memory's sake, but then immediately talk about why they're so profoundly unreliable.
Okay, yeah. Classically, you're taught to find the vertebral prominence, that's generally C7, right? And use that to approximate T1.
Yeah.
Then, using the scapula, the shoulder blade, the scapular spine is supposed to align with the T3 spinous process, and the inferior angle, the bottom tip, is meant to approximate T7.
Seems straightforward enough on paper, but the moment the patient is positioned on the operating table, those reference points just fall apart.
Why do these intuitive landmarks fail so spectacularly in the surgical setting?
Well, because surgical positioning immediately violates the normal resting posture. Think about it. The shoulders are often manipulated. They might be abducted, flexed forward, maybe placed under traction all to help get access.
Right, to open up the field.
Exactly. And that movement completely displaces the mobile scapula relative to the fixed vertebral column. So those T3 and T7 references, pretty much useless. And that's not even mentioning variations in body habitus, like obesity or maybe muscular asymmetry. It just makes palpation wildly inaccurate sometimes. So this isn't just a minor deviation we're talking about. It means that if a surgeon relies purely on palpation for landmarking, they are essentially gambling with the patient's stability and health.
That's a fair way to put it, yes.
What about anterior landmarks? Can we use those to cross-reference, maybe get a better fix?
Well, anteriorly, we can look to the superior chest wall. The T2-3 level can sometimes be inferred by the suprasternal notch, the dip at the base of the neck.
Okay.
And the T4-5 level by the palpable sternal angle, the angle of Louis.
Right.
These can give a general vertical context, maybe, but they're subject to chest wall flexibility, and frankly, they're just too far away from the posterior target to give you pinpoint accuracy.
So all this anatomical uncertainty, it really leads to one single non-negotiable conclusion, especially for elite practice in the thoracic spine.
Absolutely. The takeaway has to be absolute. No surface landmark is reliable enough to prevent wrong level surgery, period.
So imaging is key.
Intraoperative radiography isn't just a recommendation, it is mandatory. Whether you use fluoroscopy, plain film x-rays with markers, maybe preoperative CT fusion, you must achieve professional certainty by confirming the level before any irreversible anatomical sacrifice.
Like removing a spinous process or a piece of lamina.
Precisely. Before you do anything you can't undo.
Okay. So once we have that certainty via imaging, then we have to navigate the complex shield of muscle protecting the thoracic column. This defense system needs to be meticulously negotiated, particularly for those posterior approaches.
Yeah, understanding these muscle planes is absolutely vital for the direct posterior approach, which relies on creating a path of least resistance, essentially. We dissect through three primary layers.
Gray layers.
The superficial layer, this covers the biggest area, includes the massive latissimus dorsi and the trapezius muscles, the big flat muscles of the back.
Right, the ones you see, and moving inward from there.
The intermediate layer. This helps connect the spine to the ribs and the scapula. That layer comprises the levator scapulae, the rhomboids major and minor, and the serratus posterior muscles.
So these are the ones that often need to be reflected, moved aside to get deeper access.
Exactly. They have to be carefully mobilized.
Okay, and then finally the deep layer. This contains the intrinsic, sort of the postural muscles of the spine itself. This is where the dissection gets really tactical, I imagine.
It does. The deep muscles are organized into two key groups. First, there's the erector spinae group, running longitudinally, up and down. From lateral to medial, so from the outside in, these are the iliocostalis, the longissimus, and the spinalis.
Iliocostalis, longissimus, spinalis. Got it.
Second, there's the transversus spinalis group. These span shorter segments, and they run more obliquely, kind of angled between the transverse processes and the spinous process.
Okay, like connecting the different bony parts.
Exactly. And from superficial to deep, this group includes the semispinalis thoracis, the multifidus, and then the very short rotatores brevis and longus.
And the mastery here you mentioned is that when performing a posterior approach, the surgeon isn't just cutting through tissue indiscriminately, they're actually exploiting the segmented nature of the nervous system.
That's precisely it. These paraspinal muscles, they receive segmental innervation, meaning nerves branch off the spinal cord at each level to supply them.
Ah, okay.
By understanding this, the surgeon can create a safe corridor, what we call the inner nervous plane. They dissect longitudinally along the grain, so to speak, between the planes of innervation.
And that minimizes damage.
Right. It minimizes innervation and preserves muscle bulk and function far better than just, crudely cutting across the muscle bellies. It's a much more elegant and functional dissection.
Okay, muscles navigated. Now we enter what you call the high-stakes world of thoracic vasculature, starting with the really big player defining all anterior access, the aorta. Mapping its three-dimensional descent must be fundamental for planning any operation there.
Absolutely fundamental. You have to know where it is at every level. The aortic arch sort of establishes the upper boundary, typically ending around the T4 vertebral level.
T4, okay.
But its relationship with the vertebral body changes quite drastically as it travels down inferiorly. And that really transforms the exposure requirements depending on where you are.
How does it shift?
Well, initially, the descending aorta is located predominantly on the left side of the vertebral column. Makes sense, coming off the arch.
Yeah.
However, as it descends, particularly beyond the mid-thoracic region, say past T7, it begins to drift slightly more anteriorly, more towards the front.
Interesting.
And by the lower thoracic region, it settles along the left side of the distal vertebrae. This is really important because it defines the necessary clearance you need for any right-sided anterior approach in that upper segment. You have more room on the right, higher up.
Got it. And what about the three critical branches that spring right from the arch itself? These must define some serious no-go zones, especially up near the neck.
Oh, absolutely. They are the brachiocephalic trunk, the left common carotid artery, and the left subclavian artery. Any upper thoracic approach, like the trans-sternal one we'll discuss, requires extreme vigilance to avoid injuring these. Often they need careful mobilization and retraction.
Okay. Moving from the main trunk, we then have the vital segmental vessels, the intercostal arteries, that branch off the aorta at pretty much each level. They run a very specific course along the vertebral body, don't they?
They do, very specific and very tight. These segmental branches course right along the lateral aspect, sort of the waist of the vertebral body.
Right on the side.
Yeah. And critically, before they reach the costal groove on the rib, they run deep to a delicate curtain of major soft tissue structures.
The curtain of structures, like what?
You've got the azygos vein on the right, or the hemiazygos vein on the left, the very fragile thoracic duct, and the sympathetic trunk. They're all layered just superficial to the artery as it hugs the vertebra.
Wow. So that grouping means that to perform a lateral or anterior corpectomy, you're not just managing the artery and vein, you're dissecting through this whole bundle of critical systems.
That's exactly right. It's a busy neighborhood. Once the segmental vessels pass the body, they divide.
Into what?
They divide into the intercostal arteries proper, which supply the ribs and the chest wall muscles, and crucially, the radiculomedullary branches. These penetrate the neural foramina, the little holes where the nerves exit.
And these are the ones feeding the spinal cord itself.
Yes. These radiculomedullary branches are critical because they directly feed the spinal cord. And unnecessary ligation of these is a profound risk for causing spinal cord ischemia, basically a stroke of the spinal cord.
Okay, that's incredibly important. Now, you mentioned something earlier that sounded particularly interesting. Let's dedicate some serious time to this unique, hazardous architecture of the vertebral venous plexus, the VVP. You said it defines high-stakes complexity.
It really does. The VVP is truly unique in human anatomy. It's this complex, circumferential, almost sponge-like network of veins. It wraps all around the cervical sac, the covering of the spinal cord, and also around the posterior and anterior elements of the spine.
Okay, a network all around the cord.
But what makes it so fascinating and so hazardous is that it is uniquely valveless.
Valveless.
Yeah.
That sounds counterintuitive. When we talk about venous return, we normally rely on valves to make sure flow goes one way, back to the heart, right? Fighting gravity.
Exactly.
So by lacking valves, the VVP allows for free bidirectional flow. What does this two-way street actually mean functionally for the body?
Well, it creates this sort of pressure-driven freeway. Proximally, so higher up, it maintains continuity with the cerebral sinuses in the brain.
Wow.
And distally lower down, it connects all the way down to the sacral plexus in the pelvis.
So brain to pelvis, basically.
Essentially, yes. And any shift in intra-abdominal or intrathoracic pressure like coughing, straining, or even a deliberate Valsalva maneuver can instantly reverse the blood flow direction. It can shunt blood up or down the spine, completely bypassing the normal K-valve system and the filtering organs like the liver and lungs.
And this anatomical anomaly, this bypass, it explains a very specific, often devastating pattern of disease spread we see clinically, doesn't it?
It absolutely does. It's the classic explanation. In male patients, there's direct communication between this VVP and the prostatic venous plexus down in the pelvis.
Okay.
This provides a very plausible and widely accepted anatomical reason for the heightened predisposition towards spinal metastases from prostate cancer. The cancer cells basically just take this low-pressure, valveless bypass straight from the pelvis up to the spine.
Avoiding filtration.
Avoiding filtration by the lungs and liver entirely. It's a direct route.
That is a profound clinical insight based purely on this unique anatomy. Now, let's translate that hazard into the operating room. What specific dangers does this valveless system pose directly to the surgeon?
Well, the primary surgical hazard is embolization, plain and simple. If a surgeon inadvertently injures an epidural vein within the VVP, maybe apply suction nearby, or worse, if they inject bone cement, like during a vertebroplasty, into the system.
Which can happen.
It can. Then those materials, or even just air, can be drawn into this low-pressure network. And because the flow is bidirectional and connects directly, as we said, to the cerebral sinuses,
Oh, no.
these emboli can be carried straight up, cephalad, and cause a stroke or potentially fatal cerebral embolization. Surgeons have to be hypervigilant about managing pressure changes and maintaining meticulous hemostasis, stopping every little bit of bleeding in this region.
It sounds incredibly risky. Does this system offer any, advantage or utility to the surgeon, despite the immense risk?
It does offer some diagnostic utility, actually. The epidural veins within the VVP are so closely associated with the occlusal sac that they transmit pressure changes very readily.
How so?
A surgeon can use a gentle Valsalva maneuver during exploration, maybe having the anesthesiologist increase pressure momentarily to help confirm an occult CSF leak, a hidden spinal fluid leak.
Okay.
If the vein distends under pressure and the suspected leak site also bulges or shows fluid egress, it helps confirm the defect. It's a useful little trick.
Interesting. And just for completion, where does all this blood in the VVP ultimately drain into the main circulatory system?
Yeah, eventually the venous blood collected by the VVP drains into the azygos vein, which runs up the right side of the thoracic column, and the hemiazygos vein on the left side.
Azygos and hemiazygos.
Right, and these are large venous trunks, and they communicate extensively with each other at multiple levels too, creating this complex, sort of redundant venous drainage system that also needs careful management during any anterior exposure.
Okay, that venous system is clearly critical. Let's shift slightly to the bony cage itself now. The relationship between the ribs and the vertebrae is essential too, right? Especially the costovertebral anatomy.
Absolutely. The complexity starts right at the articulation, the joints. Rib heads interface with the vertebral body via costovertebral synovial joints, and the ribs also articulate with the transverse processes via costotransverse synovial joints.
So two main joint types per rib, usually.
Typically, yes. And these are reinforced by dense ligaments, particularly one called the superior costotransverse ligament.
Why is that specific ligament so important? What makes it stand out?
Well, that ligament, it spans from the neck of the rib below up to the transverse process above, and in doing so, it forms a kind of tunnel.
A tunnel containing what?
Passing directly through that tunnel are the dorsal ramus of the spinal nerve, that's the branch going to the back muscles and skin, and the dorsal branch of the intercostal artery.
Okay, neurovascular structures right there.
Exactly. So any surgical manipulation in this region, like during a costotransversectomy, has to respect the neurovascular contents running through that specific bony ligamentous tunnel.
Got it. And finally, maybe the life-saving detail for any approach that involves working along the rib itself. The specific, non-negotiable order of the intercostal neurovascular bundle.
This mnemonic is paramount, absolutely paramount for preventing iatrogenic injury, accidental damage. The bundle runs along the inferior border, the bottom edge of the rib.
Okay, along the bottom.
And it runs in the order VAN, van, from cephalid to caudal, so from top to bottom. Vein, artery, nerve.
Vein, artery, nerve, VAN.
Correct. So when establishing portals in endoscopic surgery or making incisions in open thoracotomy, all dissection near the rib must happen along the superior margin, the top edge of the rib. That keeps you safely above this vulnerable bundle.
Always stay high on the rib.
Always stay high.
And one last bony articulation fact. You mentioned something about demifacets.
Right. Just a detail, but important for planning. The standard rule is that ribs 2 through 10, they sort of straddle the disc space. They articulate with two vertebral bodies via these things called demifacets, half facets.
Okay.
The exceptions are ribs 1, 11, and 12. These articulate solely with their own corresponding vertebra, just one. This changes the anatomy slightly when you're planning a rib head resection during certain anterolateral approaches. You need to know which pattern you're dealing with.
Okay, we've navigated the landmarks, the muscles, the complex vascular and bony anatomy. Now let's dive into surgical technique itself, starting with probably the most common route. Approach A, the direct posterior exposure. This is used primarily for things like decompression and putting in instrumentation, right? Screws and rods.
That's its main purpose, yes. It begins pretty straightforwardly with a midline skin incision right over the spinous processes, those bumps you feel down your back. The crucial step, though, is the meticulous dissection that follows. Electrocautery, usually, is used to incise through the fat and the fascia covering the superficial muscles, which gets you down to the deep paraspinal muscles we discussed earlier.
And you mentioned before, the goal here isn't just to slice through muscle, but to exploit that inner nervous plane. How does the surgeon actually achieve that technically during the dissection?
The technique is called subperiosteal dissection. It means performing the dissection right on the bone. You release the insertion points of those spinotransverse muscles, the erector spinae and transversus spinalis groups, right where they attach to the spinous processes and laminae.
Using what?
Using sharp and blunt periosteal elevators. Tools designed to lift the periosteum, the covering of the bone, along with the muscle attachment.
Ah, so you're peeling the muscle off the bone at its attachment point.
Exactly. By releasing the insertions, you can reflect the entire muscle mass laterally as one unit, preserving its bulk, its function, and importantly, that segmental innervation we talked about.
That makes the process sound much more deliberate and, well, anatomical than just cutting muscle fibers. Are there any anatomical features that offer some natural protection during this initial bony exposure?
Yes, thankfully the anatomy helps, particularly in the upper thoracic spine. The laminae and spinous processes back there are heavily shingled. They overlap quite significantly, like roof tiles pointing downwards and backwards.
Okay, I can picture that.
This downward and posterior orientation physically protects the underlying spinal canal from inadvertent entry by surgical instruments during that initial phase of exposure. It provides a bit of a bony shield.
That's helpful. What are the immediate hazards, though, that an elite professional has to anticipate during this reflection process? What can go wrong right here?
Well, beyond ensuring you're truly staying subperiosteal, you have to be careful with the ligaments if a fusion isn't planned. You want to try and preserve the intertransverse membranes, the facet joint capsules, and the inner spinous and supraspinous ligaments if possible.
Right, to maintain stability.
Exactly. More acutely, though, there is a definite risk of brisk bleeding. If you dissect too aggressively or too deep, especially out towards the lateral margins of the facet joint, near the pars interarticularis.
The pars.
Yeah, that segment of bone connecting the facet joints. Exposing that area too zealously frequently risks injuring an underlying vein that can bleed, well, quite vigorously and really obscure your field of view quickly. Needs careful hemostasis.
Okay, vigilance required even in the standard approach. Now let's pivot to approach B, the costotransversectomy. This sounds powerful because it allows a surgeon to reach the anterolateral spine, the front and side, while starting from the back.
It's a vital technique, absolutely. It's designed for dealing with anterior pathology, things like a partial corpectomy, removing part of the vertebral body, a full vertebrectomy, or maybe a complex 3-column osteotomy pathology that you just can't reach safely from a purely midline posterior incision.
So describe the path taken. You start with the standard posterior exposure we just discussed.
Yes, the standard posterior exposure is the starting point. But then the dissection is deliberately extended much further laterally, way out beyond the lamina, over the transverse process and actually onto the rib itself.
Okay.
So for instance, to access the T6-7 disc space from behind, the surgeon would focus their lateral dissection on the T7 transverse process and the adjacent 7th rib.
And this involves controlled sacrifice of some bone to create the working channel, doesn't it?
It does. That's the atectomy part. The transverse process associated with the target level is excised first. Then, the surgeon performs a careful superiosteel elevation of the dorsal periosteum, the back surface covering, of the medial, say, 6 centimeters of the rib.
Lifting the covering off the inner part of the rib.
Right. The rib is then cut about 6 centimeters out, and the rib head, where it joins the spine, is disarticulated from the vertebral body. Removing that segment of transverse process and rib creates this deep angled working corridor towards the side and front of the spine.
Once that window is created, the surgeon is suddenly right next to the chest cavity. What structures pop into view that need careful visualization and management before proceeding deeper towards the vertebral body itself?
Yeah, you're right at the edge. The deep rib periosteum and the sensitive parietal pleura, the lining of the chest cavity, are immediately visualized. The pleura absolutely must be protected, or if entered, managed very carefully.
Okay.
And crucially, remember those segmental vessels we talked about, wrapping around the vertebral body waist. They now come into view in this lateral corridor. They must be identified and either managed meticulously with bipolar cautery or carefully ligated if they directly obstruct the view or access to the vertebral body waist where the work needs to happen.
And before starting any major bony resection on the vertebra itself, protecting the great vessels and other internal structures is paramount, I assume.
Absolutely non-negotiable protection. A specially contoured retractor designed for this approach is wedged anteriorly between the spine and the contents of the chest. It shields the pleura, the great vessels, like the aorta sitting there on the left, and other mediastinal structures from the high-speed burrs or rongeurs that are used on the vertebral body.
Makes sense. You noted earlier that an alternative incision exists for this if only anterolateral access is the goal, not posterior instrumentation.
That's right. Instead of the standard midline incision used when posterior fixation is also planned, a surgeon can opt for a curved parasagittal longitudinal incision. This is made off the midline, splitting directly through the trapezius and paraspinal muscles right over the area of the costotransverse junction you want to expose. It focuses solely on creating that anterolateral access window.
Okay. Moving on to approach C, the transpedicular approach. This is often described as the more minimal, maybe elegant solution for getting to a disc posteriorly.
It often is, yes. It's considered the gold standard for safe, unilateral, posterior access to discs or perhaps smaller tumors, provided the neural status allows for it. We'll get back to that caveat.
Right.
Its main strength lies in avoiding iatrogenic instability. You're not removing as much bone as other approaches and minimizing any unnecessary manipulation of the spinal cord itself.
So again, we start with the posterior exposure. How does the surgeon define the specific safe bony window for entry in this technique?
Well, fluoroscopy is used constantly here to confirm the level. The focus is squarely on the lamina and the facet joint complex that directly overlies the target disc space.
Okay.
The surgeon uses a high-speed burr to perform a very precise measured bone removal, a partial facetectomy, removing part of the facet joint, and a hemilaminotomy, removing part of the lamina on one side.
And you mentioned the ligamentum flavum earlier, that tough yellow ligament. It plays a key role here as a buffer zone.
It's the crucial anatomical safety net in this approach. As the surgeon carefully burrs away the caudal edge, the bottom edge of the lamina above, and the medial part of the facet joint,
Right.
they uncover the ligamentum flavum, which lies directly over the dura and the phakical sac. It acts as a protective barrier, a buffer, until the surgeon can fully and safely excise it using specialized instruments like Harrison rongeurs. This prevents inadvertent dural tears or direct contact with the cord during the bony work.
Very clever use of anatomy. The ultimate visualization goal, the source says, is to expose the medial half of the pedicle, that bony bridge connecting flat and back in cross-section. What does the surgeon actually see and have to work around in that final, quite small operative window?
Yeah, the working window is definitely tight. It provides 4 vital reference points, sort of the corners of your safe zone. You see the axilla or the inferior angle of the exiting nerve root as it leaves the spine.
Okay, the nerve root going out.
Then you see the shoulder, the upper part, of the traversing nerve root heading down to the level below. You also see the lateral border of the scrotal sac itself.
The edge of the cord covering.
Exactly. And then, hopefully, the disc space itself. The surgeon might need to thin the inner wall of the pedicle a bit with the burr to improve the view, but they are working in extremely close proximity to all these neural elements.
So neural protection must be absolutely mandatory here.
Oh, absolutely. The delicate nerve root retractors or fine Penfield instruments are often used to gently protect the exiting and traversing nerve roots. This can demand very careful, minimal retraction.
And bleeding.
Yes. Frequently, the surgeon encounters epidural vessels within this small window. They have to be managed meticulously, usually with bipolar cautery, to maintain a clear, bloodless field, which is critical when working so close to the nerves.
Okay, and this brings us right back to that critical decision matrix, the caveat you mentioned earlier.
Yeah.
When is this elegant, minimal, transpedicular approach absolutely the wrong choice? When is it contraindicated?
And this really is the hallmark of surgical mastery. Knowing when not to do something, when to abandon a less invasive technique for a safer, albeit bigger, operation.
So when is it contraindicated?
The transpedicular approach is contraindicated if the spinal cord is already significantly compressed and flattened, what we call myelopathy, or if there's effacement of the CSF on the MRI. That means the spinal fluid space around the cord is obliterated and the cord is pressed directly against the surrounding bony structures or the disc herniation itself.
Because there's no room left.
Exactly. In that critical state, there is simply no anatomical space left. There's no buffer zone to safely manipulate or retract the navicle sac or the nerve roots without causing direct, potentially devastating mechanical injury to the already compromised spinal cord. The risk is just too high.
Right. So if the pathology is ventral on the front side, and that posterior transpedicular approach is too risky because the cord is flattened, we have to turn to the more aggressive access provided by approach D, the anterior open transthoracic approach. This gives that wide-open exposure needed for major reconstructions like corpectomy, tumor resection, circumferential fusion.
Exactly. This is a major undertaking, and it demands significant preparation, starting with positioning the patient laterally, usually with the operative side facing up. But the choice of which side to enter from left or right is a really pivotal planning step. It's guided entirely by the underlying anatomy at the level you need to reach.
Okay, let's nail down those critical rules for side preference in the thoracic spine. This seems really important.
It is. For the upper thoracic spine, let's say roughly T1 through T7, the right side is generally preferred.
Right side for upper thoracic. Why?
The primary reason is to avoid having to mobilize the heart and the great vessels, which are predominantly on the left. And crucially, it's thought to lower the probability of damaging the artery of Adamkiewicz, that major cord feeder, which typically enters from the left side more often in this upper segment.
Okay, avoid the heart, avoid the big artery. Makes sense. And what about for the lower thoracic spine, say T8 and below?
There, we generally shift preference to the left side. The major driver for this choice is avoiding the liver. The liver sits high up under the diaphragm on the right and significantly encroaches into the right lower thoracic field, making access much more difficult.
Okay, so right side high up, T1, T7, to avoid heart aorta Adamkiewicz, left side lower down below T7 to avoid the liver. Got it.
That's the general rule, yes.
So once the site is chosen, we know we're entering the chest cavity proper. This requires specific lung management, right?
Yes, it does. Double lumen bronchial intubation or bronchial blocker is necessary. This allows the anesthesiologist to selectively deflate the ipsilateral lung, the lung on the operative side, once the pleural space is entered.
To get it out of the way.
Exactly. It maximizes the operative working space dramatically.
Where is the optimal incision usually made for accessing the majority of the thoracic column through this approach?
A long, curvilinear incision following the line of a rib is standard. The intercostal space between the 5th and 6th ribs usually provides the best overall access window for most mid-thoracic levels.
5th and 6th rib space.
Okay. If you're targeting lower down, say T10, 12, you might need to use the space between the 6th and 7th ribs. Though the surgeon has to be aware that later on, the formation of a bony callus or scar tissue from the rib resection here can sometimes lead to a painful, symptomatic clicking of the scapula postoperatively. It's a known potential complication.
Interesting. And the rib itself, how is it managed? Is it always removed?
Rib management is flexible. It's
Yeah.
often dictated by whether you need bone graft material for the reconstruction. Superior steel dissection of the rib, peeling the covering off, is always performed first.
Right.
If autogenous bone graft, meaning graft from the patient themselves, is needed for the fusion or reconstruction, then that rib segment is stripped circumferentially and harvested.
Okay. Use it for parts.
Yeah. If no graft is required, the surgeon might leave some of the soft tissue attachments on one side. This allows the rib segment to be kind of hinged back, used almost like a trapdoor to help facilitate a more tension-free closure at the end.
Clever. Now, the vascular hazards during this anterior exposure sound immense, maybe even far exceeding the posterior risks we discussed.
They are significant, yes. Remember that VAN bundle. The intercostal artery and vein hug that inferior border of the rib above the space you're entering.
Right. Stay high on the rib below.
Exactly. Surgeons rely on the general anatomical principle that the disc spaces themselves usually sit between the segmental vessels branching off the aorta. But crucially, before the parietal pleura can be elevated off the side of the spine to expose the vertebrae,
Yes.
the segmental vessels that are seen traversing the planned operative window must be definitively ligated and/or cauterized first.
Why must the timing of that ligation be so precise? Why before lifting the pleura?
Because if you try to elevate the pleura before dealing with those vessels, they're under tension, and they will likely tear and retract back into the mediastinum, the space between the lungs. Trying to control bleeding from a retracted vessel back there is incredibly difficult and dangerous.
Okay, control them before you mobilize.
Absolutely. And furthermore, there's always the ever-present caution we mentioned. Excessive ligation of segmental vessels, especially multiple levels in a row, carries that serious risk of devascularizing the spinal cord, leading directly to potentially catastrophic spinal cord ischemic injury. It's a constant balancing act.
Balancing access and perfusion, what about managing the major viscera, the organs that might be overlying the vertebral bodies, particularly on the right side?
Good point. On the right side, specifically, the large azygos vein and the esophagus lie directly over the anterolateral aspect of the spine. After the pleura is opened and reflected, these structures must be very carefully mobilized and retracted anteriorly towards the front to safely expose the lateral and ventral surfaces of the vertebrae and discs you need to work on.
Okay, careful mobilization there.
Yeah.
Now let's discuss two other critical structures mentioned in the sources: the sympathetic trunk and the extremely fragile thoracic duct.
Right. The sympathetic trunk ganglia, these little nerve bundles, they tend to overlie the heads of the ribs in the upper spine, but they shift a bit more anteriorly onto the vertebral bodies themselves in the lower spine.
Okay.
While sacrificing a few individual ganglia might sometimes be necessary to get clear exposure, the main trunk itself and the distal splanchnic nerves branching off it must be preserved whenever possible to prevent permanent autonomic dysfunction, like changes in sweating or bowel function.
And the thoracic duct, the source, describes it as delicate and white. What exactly is the consequence of injuring this structure? It sounds serious.
It is very serious. The thoracic duct is the main conduit in the body for lymph fluid and chyle, which is digested fat from the intestines. Its location is somewhat variable, but in the lower thoracic spine, it's typically found anterior to the vertebral bodies.
Okay.
It then deviates sharply over to the left side around the T5 level, heading up towards the neck. It eventually drains into the venous system near the junction of the left internal jugular vein and the brachiocephalic vein.
And if it's injured?
Injury leads to a persistent, often high-output postoperative chyle leak, basically, lymph fluid leaking into the chest cavity. This is called a chylothorax. It's associated with significant nutritional depletion, electrolyte imbalances, and historically a high mortality rate if it's not recognized and requires immediate surgical repair, usually ligation. Protecting that duct, especially during left-sided anterior approaches, is an ongoing major priority.
Wow, okay, that's a critical hazard. Now, Approach E, the endoscopic approach, seems to offer the same kind of anterior access but through a minimally invasive technique.
That's the idea, yes. It mirrors the goals of the open transthoracic approach, things like discectomy, maybe placing a small graft or doing a biopsy, but it uses several small portals, maybe 2.5 centimeter incisions, instead of one large thoracotomy incision.
Position is still lateral.
Yes, the patient is positioned laterally. Again, the right side is often preferred for general access, but if there's scoliosis, you might position with the convexity upwards. And critically, the surgeon must always drape very widely, preparing for the possibility of needing immediate conversion to an open thoracotomy if complications arise or visibility is poor.
Safety first. You mentioned portals. How is safety ensured during portal placement given that VAN neurovascular bundle running along the rib edge?
This is a classic example of applying that anatomical knowledge directly for safety. The portals are typically established using blunt dissection and passage of trocars or instruments, and this passage must occur directly over the cephalad edge, the very top surface of the selected rib.
Again, stay high on the rib.
Always stay high. This ensures the tools pass safely caudal to or below the intercostal muscles, keeping them well above the neurovascular bundle that travels along the inferior border of the rib above. It minimizes the risk of nerve injury or bleeding from those vessels.
Makes sense. Let's move to approach F, the lateral extracavitary approach. This sounds like a real display of surgical ingenuity, offering potentially 360-degree working environment, but through a single posterior incision.
It's a very versatile approach, often favored for complex pathology at the thoracolumbar junction, where the thoracic spine meets the lumbar spine. It's particularly useful for things requiring circumferential stabilization, like big tumor excision or debriding nasty infections, where you need to address both the anterior column support and place posterior instrumentation like screws and rods.
That dual access from a single posterior incision sounds immensely complex to achieve. Can you describe the incision and the key step in muscle mobilization that allows this?
Sure. The patient is positioned prone, face down, often with the surgical side slightly elevated using bolsters or by tilting the table. The incision is typically a large, curvilinear one, sometimes called a hockey stick incision. It starts and ends at the midline, spanning maybe 3 vertebral levels proximal and 3 levels distal to the main target level.
Okay, long incision.
Yes. And the apex, the curve, sweeps out quite far laterally, perhaps 7.5 centimeters or more off the midline. After the standard direct posterior exposure is done along the midline part, the latissimus dorsi and the paraspinal muscles are mobilized laterally, pulling them away from the spine.
And the key step.
The key step is making a vertical incision or split through those mobilized muscles right at the apex of the skin incisions curve.
Ah, splitting the reflected muscle flap.
Exactly. That split at the apex provides the direct lateral working corridor down towards the ribs and transverse processes.
And that allows the anterior access.
Yes. Through that lateral window created by splitting the muscles, the surgeon then performs the excision of the proximal 6 centimeters of rib and the associated transverse process, very similar to the costotransversectomy technique we discussed.
Okay.
This opens up the access to the lateral and anterior aspects of the vertebral body for the corpectomy, debridement, or graft placement. The real genius of this approach lies in the fact that the surgeon can perform all the necessary anterior column work first.
Right.
And then, by simply retracting that posterior muscle mass laterally again, they can access the posterior elements, laminae, facets, pedicles, to perform the posterior instrumentation and fusion, all through the same initial skin incision. It avoids needing a separate anterior incision.
Truly 360 access from one approach. Very powerful. Finally, approach G, the trans-sternal approach. This sounds like it's reserved for the really difficult uppermost thoracic spine, the cervicothoracic junction.
That's exactly its niche. It targets the uppermost thoracic vertebrae, maybe T1 down to T3 or T4.
Fine.
The distal limit is often constrained by the highly variable location of the aortic arch. The patient is positioned supine, face up, usually with the neck in slight extension to help bring the structures forward. This is a region absolutely dense with critical neurovascular structures.
And this is an approach where side-specific risk assessment seems paramount again.
Absolutely critical.
Yeah.
A left-sided dominant approach, or significant retraction to the left, necessitates absolute protection of that very delicate thoracic duct as it ascends into the neck.
Okay, protect the duct on the left.
And a right-sided dominant approach demands extreme vigilance regarding the recurrent laryngeal nerve. It loops under the subclavian artery on the right and is very vulnerable to traction injury or thermal injury from cautery, which can result in potentially permanent vocal cord paralysis.
Hoarseness or worse.
Okay.
Detail the required osteotomy, the bone cutting, needed to open this window through the sternum.
The skin incision usually runs along the anterior border of the distal sternocleidomastoid muscle in the neck, curves down to the manubrial notch, the top of the sternum, and then continues about 3 centimeters down the midline of the sternum itself. The surgeon first needs to release the interclavicular ligament connecting the collarbones and detach the strap muscles, the sternohyoid and sternothyroid muscles, from the back of the manubrium.
Clear the soft tissues.
Right. Then, an oscillating bone saw is used to cut the manubrium, the top part of the sternum, full length right down the midline, usually extending down to the level of the T2-3 intercostal space. This is followed by a transverse cut across the sternum at that lower level.
Creating what shape?
The surgeon can choose either an inverted T-shaped cut, which allows for bilateral retraction of the manubrial halves, or an L-shaped cut for unilateral retraction if less exposure is needed. And sometimes, to enhance visibility and get more lateral retraction, an osteotomy, a cut of the distal clavicle, the collarbone, can also be performed. This really allows the manubrium half to be pulled much further laterally.
Okay, that opens up the space significantly. What are the immediate neurovascular hazards lying right there in the floor of this approach, just lateral to the main dissection?
There's a big one to remember here. Immediately lateral to this exposure, remember the phrenic nerve, which controls the diaphragm, runs down directly overlying the scalene muscles. It must be identified and protected from retraction injury or cautery. Phrenic nerve palsy is a serious complication.
Critical point. Once the sternum is opened and retracted, how is the final deep working window defined? What are the boundaries?
The deep working window is essentially bounded by the common carotid artery on the left side and the brachiocephalic artery and vein on the right side. The esophagus forms the posterior floor of this exposure, lying right on top of the spine.
So you have to move everything out of the way.
Carefully, yes. The surgeon must gently retract the esophagus, the trachea, and the recurrent laryngeal nerve, usually, over to the patient's right. The internal jugular vein and the carotid sheath contents are retracted to the left. This exposes the prevertebral fascia covering the spine. Once that's open, the longest calling muscles running along the front of the vertebrae are revealed, and these must then be elevated off the spine to finally expose the anterior vertebral bodies of T1, T2, T3. It's a deep, complex window.
Okay, we've gone through a huge amount of complex anatomy and demanding surgical approaches. It seems clear that mastery in the thoracic spine is really defined by anticipating failure, by knowing all the things that can go wrong. Let's try to consolidate the most critical anatomical hazards that form that elite professional checklist.
Absolutely. Starting with straightforward vessel injury, particularly those intercostal vessels we keep mentioning. If they're injured during exposure or resection, they require immediate, definitive management, either cauterization or ligation.
Why media?
Because if they retract back into the soft tissues or the mediastinum, achieving hemostasis, stopping the bleeding, becomes notoriously difficult and can lead to significant rapid blood loss, completely compromising the operative field and patient stability.
Okay, control bleeding fast. Then there's the risk of spinal cord ischemia. You've mentioned this multiple times, and it's arguably the most feared complication, right? Given the thoracic cord's unique vulnerability.
It is arguably the most feared, yes. And the vulnerability really comes from two main places. First, the upper thoracic cord is often described as a watershed zone anatomically. It relies on a somewhat tenuous, delicate balance of arterial supply from those small radicular arteries.
Making it susceptible.
Yes, inherently more susceptible to drops in perfusion. Second, and more critically perhaps for anterior surgery, is the artery of Adamkiewicz. This is the major arterial feeder for the distal spinal cord, but its location where it enters the spinal canal is highly inconsistent between individuals.
So you can't reliably predict which segmental artery feeds it.
Exactly. You can't reliably predict which segmental vessels are safe to ligate during an anterior approach without risking taking out the Adamkiewicz and causing paralysis. The overriding rule remains: minimize segmental vessel sacrifice whenever possible to minimize that ischemia risk. Be judicious.
Very clear. What about the risks associated directly with the neural elements themselves, the cord and nerves?
The fundamental rule here is strict. Avoid unnecessary contact with the spinal cord, period. This is precisely why technique selection matters so much, as we discussed with the transpedicular approach.
Right.
If your surgical objective inherently requires manipulation of the dura or retraction of the neural elements to get to the pathology, then you must choose an approach, like the transthoracic, that provides sufficient space to work away from the cord, rather than risking direct contact in a narrow posterior corridor where there's no room to maneuver safely.
Don't touch the cord unless absolutely necessary and only with adequate space. We also discussed the unique CSF leak hazard related specifically to the thoracic cavity.
Yes, it's different from leaks elsewhere. A CSF leak that persists or goes unrecognized after thoracic spine surgery can actually fill the pleural space with spinal fluid. This can lead to a tension hydrothorax, which essentially collapses the lung and presents as severe, acute respiratory compromise.
That sounds dangerous.
It's an unusual complication compared to lumbar or cervical leaks, which usually just cause headaches or local collections, but it's potentially fatal in the chest if not recognized and drained promptly, often requiring a chest tube.
Okay. And circling back to that extremely delicate non-vascular structure we highlighted during the anterior approach discussion.
The thoracic duct.
Yes.
Injury to that white, wispy structure is a major hazard of anterior, especially left-sided approaches. The resulting persistent chyle leak, the chylothorax,
We heard how bad that is.
can lead to severe fluid and electrolyte imbalances, malnutrition, immunosuppression, and carries a high mortality rate if the defect isn't identified and repaired surgically, usually by direct ligation of the duct. Protecting that duct is an ongoing, constant priority during those approaches.
Got it. And finally, let's revisit the ultimate hazard we began with, the one that seems simplest but is maybe most prone to human error: preventing wrong-level surgery.
It sounds basic, but it still happens. Mandatory imaging is the absolute foundation of professionalism here. The elite professional relies on redundant checks.
Like what?
Things like careful preoperative counts of vertebrae and ribs on imaging studies, perhaps placing radio-opaque markers like a clip on a specific, easily identifiable rib during exposure that can be confirmed on an intraoperative X-ray. And absolutely, the mandatory use of intraoperative fluoroscopy or plain film X-rays to definitively confirm the correct vertebral level before the first irreversible cut is made, before the first piece of lamina or spinous process is removed. No guessing.
Verify, verify, verify.
Yep.
Okay, let's try to apply this all these concepts to the clinical case provided in the source material. A 35-year-old male presenting with severe thoracic myelopathy, meaning spinal cord dysfunction, caused by a large disc herniation at the T67 level. The MRI reportedly shows the herniation is so large it causes effacement of the CSF space and visible flattening of the spinal cord.
Okay, yeah. This scenario is the perfect illustration of that surgical calculus we've been talking about. The patient clearly requires decompression to relieve the pressure on the spinal cord. The two main logical surgical options would be the transpedicular approach from the back, which is more minimal, or the transthoracic approach from the front, which offers much wider exposure.
So why does the description of CSF effacement and spinal cord flattening on the MRI immediately rule out the more minimal transpedicular approach in this specific case?
Because that flattening and effacement tells you critical information. The cord is already tight against the dura, and the dura is tight against the bone or the disc itself. There is zero margin for error. There's no slack in the system.
No buffer zone left.
Exactly. The inherent nature of the transpedicular approach, which, as we discussed, requires working in a very narrow angled window and potentially involves some degree, however slight, of retracting the locus sac to see the disc, becomes prohibitively dangerous. Any attempt to manipulate or move that already compressed, flattened cord within that tight space risks causing direct mechanical trauma and worsening the neurological injury.
So even though the transthoracic approach is much more invasive, requiring opening the chest, deflating a lung, etc., it becomes the mandatory path for maximal safety here.
Precisely. The transthoracic approach allows the surgeon to perform the corpectomy or discectomy ventrally from the front. They are approaching the pathology, the disc herniation, and physically moving the compressing material away from the spinal cord without ever having to touch or retract the compromised neural elements from behind.
Working away from the cord, not towards it.
That's the key concept. Surgical mastery in this instance means accepting the increased physiological invasiveness and complexity of an anterior approach specifically to ensure neural safety, because the posterior route is anatomically contraindicated by the severity of the spinal cord compression shown on the imaging. It's about choosing the safest path for the cord, even if it's a bigger operation overall. #tag outro.
Wow. This deep dive has truly illuminated why the thoracic spine demands such a unique level of anatomical respect, really unlike almost any other area of the body. We've navigated the illusory nature of those surface landmarks, mapped the critical descent of the aorta, explored the valveless venous plexus, and understood the delicate balance required when dissecting around structures like the thoracic duct.
Yeah, hopefully this synthesis reinforces that understanding that mastering the thoracic spine isn't just about knowing procedural steps. It's a deep synthesis of risk management, intricate anatomical knowledge, and precise surgical technique. That decision between posterior, lateral, or anterior access isn't arbitrary. It's a complex matrix dictated entirely by the specific pathology, the extent of reconstruction needed, and most critically, as we just saw, the status and vulnerability of the neural elements.
That T67 case really did perfectly encapsulate that ultimate surgical trade-off.
Yeah.
Invasiveness versus neural safety.
Exactly.
So what does this all mean for the listener? I think it underscores that surgical success in the thoracic spine rests entirely on respecting its tight, unforgiving boundaries. Those valveless veins, the critical segmental arteries feeding the cord, the easily injured pleura and duct, and of course the highly susceptible spinal cord itself. The elite professional doesn't just know the steps. They deeply understand the consequences of every single cut, every retraction, every ligation.
Well said. And maybe we can leave you, the listener, with this final provocative thought, reflecting once more on that unique vertebral venous plexus, the VVP.
Okay.
We discussed how prostate cancer cells can utilize this valveless bidirectional freeway to travel directly from the pelvis to the spine, bypassing the typical filtering systems of the liver and lungs.
Right, the metastatic pathway.
Now consider the implications beyond cancer. Think about systemic infection. If a patient develops an infectious focus somewhere else in the body, say bacterial endocarditis on a heart valve, or maybe a deep abdominal abscess, could that infection potentially use the VVP as a similar conduit? Could bacteria seed directly into this valveless plexus, completely bypassing the normal liver and pulmonary filters, to cause an otherwise inexplicable spinal epidural abscess, or perhaps even seeding up to cause a cerebral infection or meningitis?
Wow, that's a chilling thought. A hidden highway for infection, too.
It's a plausible anatomical pathway. Just knowing about this unique structure, the VVP, and its bidirectional flow profoundly alters how clinicians might need to think about the entire spread and trajectory of certain diseases throughout the human body, far beyond just surgical access. It's a fundamental piece of anatomy with system-wide implications.